بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا يا كريم. Dear colleagues, we'll start now one of the important lectures in the pediatric imaging, and it will deal with the cerebrovascular stroke and imaging of trauma. As you all know, we usually evaluate the brain by CT in cases of emergencies, and I have discussed the way how to assess the brain by CT scan in the lectures previously introduced about imaging of the normal adult brain and also imaging of the normal pediatric brain. And just to remind you about the way we usually examine the patient before contrast injection, then we look at the scan and we assess if we are in need to inject contrast or not. Sometimes we want to sedate the child, and in both cases, whenever we are intending to give contrast media or give sedation, the patient should fast for at least 3 hours. Then we usually do not need to inject the contrast media whenever the brain scan is normal or we have diagnosed atrophic changes or hemorrhage or infarction. But we need to inject the contrast material whenever we are suspecting intracranial infection or we want to accurately diagnose some of the intracranial neoplasms. And the child is put in the spine position, and we have the scanogram in the lateral view, and our scanning area starts from the skull base at the orbitomeatal line, which is the line passing from the external cancers to the external auditory canal, and we proceed from the skull base to the vertex of the skull. We usually use the 7mm scan intervals for children and the 5mm scan intervals for infants. Then in our domain, we have to differentiate between two main CT appearances, and these are what we call the hypodense lesion, which is a lesion that is relatively black compared to the normal brain tissue. And in such a case, we are dealing with an ischemic or infarcted brain tissue. And the second is the hyperdense lesion, which is a lesion that is more bright or more dense than the normal brain parenchyma. And in such a case, we are dealing with hemorrhage, and sometimes calcium may give similar appearances. Then why the lesion appears hypodense or hyperdense, and this is related to what is known as the CT density or the attenuation value, and this attenuation value is measured by the Hounsfield units. And you know that Hounsfield was the British physicist who introduced the CT machine in the late 70s. And the normal brain tissue, the attenuation value of the normal brain tissue ranges between 30 and 40 Hounsfield units. And any normal structure or lesion which measures below 30 will appear black, and another lesion which measures above 40 will appear relatively bright. And CSF, the attenuation value of CSF is about ranges between 0 and 15 Hounsfield unit. That of the fat, like this in the orbital fat, measures minus values starting from minus 10 up to or down to minus 200. In air, we'll measure air in the paranasal sinuses, air in the mastoid air cells. We'll measure in attenuation value much lower CT attenuation, minus 300 and now. Then the infarction or the ischemic brain tissue will measure about 20, in the range of 25 ounce field unit. Brain edema surrounding tumor or inflammatory lesion measures about 20 ounce field units, and the cyst in the brain will appear hypodense like this one, depending on the contents of the cyst, whether it is an arachnoid cyst or epidermoid cyst or hydatid cyst, for example. All these have different attenuation values, but they appear black compared to the normal brain parenchyma. Then hyperdense lesions or lesions that are more bright than the brain parenchyma include hemorrhage, and this is an example of an epidural hematoma in the right frontal region, which is very bright compared to the brain parenchyma. And the second bright lesion is calcium, and calcium will appear more dense than the brain parenchyma and more dense than hemorrhage as well. Hemorrhage measures 60 to 90 ounce field unit, while calcium will measure above 200 ounce field units. Then the pediatric cerebrovascular diseases will be handled in these topics. Number one, the hypoxic ischemic encephalopathy, which is a major issue in the pediatric age group. Then we will have some idea about the non-accidental trauma, and will have a good explanation about the traumatic cerebrovascular injuries in the pediatric age group, and this include a lot of lesions. Then finally, we'll have some words about the vascular intracranial lesions in children. You know that neonatal encephalopathy is a big term which includes many conditions, and this hypoxic ischemic encephalopathy is one of them. The hypoxic ischemic encephalopathy is one of the common causes of severe neurological deficits in children, and this is the incidence is about 6 every 1,000 live births. And you know the difference between hypoxia and ischemia. Hypoxia means diminished oxygen content to the blood, and ischemia means that there is decrease in the cerebral blood flow. Then we have to discriminate the changes in the neonates, considering whether they are preterm or full-term infants. The premature infants will have different lesions compared to those born at the normal expected gestational age. Then there are marked difference between the changes seen in the preterm infant compared to the term infant. In the preterm, we have these abnormalities, including periventricular leukomalacia, the germinal matrix hemorrhage, intraventricular and intracerebral hemorrhage. While in the term infant, we have the global ischemia, the watershed ischemic changes, the infarction similar to the adults, and also the focal ischemic changes. Then why this difference is present? That's because of the appearance of the blood supply to the brain tissue, which is different from the preterm compared to the term infant. In the preterm or the premature neonate, the brain has a ventricular-pedal vascular pattern, and hypoperfusion will result, as you can see from this drawing, in the area intimately related to the ventricular wall. While in the term infant, there is a ventriculofugal vascular pattern, which indicates that most of the insults will be approximately within the gray-white matter region or somewhat away from the ventricular wall. Then the hypoxic ischemic encephalopathy in general, in the term infant, will present clinically by these manifestations. As you all know, or the pediatricians know, that a patient will have a low Apgar score at the delivery, and this will include the slow heart rate, poor respiratory effort, abnormal skin color, decreased level of alertness, and abnormal muscle tone, and also maybe weak or absent cry. Then there may be metabolic acidosis in the spinal cord blood sample, and the patient early in his life will develop seizures and abnormal EEG results. Then, if we are talking about the preterm infant or the premature infant, we have the four lesions mentioned before, and these are the periventricular leukomalacia, the germinal matrix hemorrhage, intraventricular and intracerebral hematomas. And you remember that most of these lesions will occur in the periventricular area due to the development of the blood supply to the brain tissue in this particular age group. Then the periventricular leukomalacia means that there is ischemic changes in the white matter, and this will appear immediately related to the wall of the ventricle. The ischemic white matter will appear hypodense or in the CT scan and of low signal in MRI, T1 and the high signal and T2 weighted images. These hypoxic white matter will progress rapidly to form cystic areas of encephalomalacia, and this will affect the appearance of the ventricle, which at this time the ventricle uh, will have will have a characteristic appearance, as you can see. Then this abnormality is commonly seen in the premature infants, and they are now every premature infant should be checked for the presence of these complications, including the periventricular leukomalacia and the germinal matrix hemorrhage. In cases of leukomalacia, as I mentioned, there are areas in the white matter intimately related to the ventricle. They are of low signal in the T1 and high signal in the T2 weighted images. And also, ultrasound is very helpful, transcranial ultrasound, in detection of the cystic changes in the white matter in around the ventricles. These patients will clinically complain of some relatively characteristic manifestations, and this is one of them, which is the spastic diplegia or paraplegia, and also they may have some attacks of seizures. Then the periventricular white matter will be affected, and these are the most common sites are the trigone of the lateral ventricles in this area, and the cerebral white matter around the region of the foramina of Monroe. In here, you can see in this MRI T2 weighted image that the white matter around the ventricles appear relatively scanty, and it showed abnormal signal together with the lobulation of the ventricular wall, which is the result of periventricular leukomalacia. Extensive necrosis of the deep white matter adjacent to the ventricles will result in the decrease of the mass of the white matter. And you can compare here the white matter in the frontal lobe, which is relatively good, to the white matter in the occipital lobe, which is reduced in size, together with increase in its signal in T2 and also in the FLAIR weighted images. The incidence is about of this, according to the literature, about 70% of the preterm this disease is seen in 70% of the preterm infants with hypoxic ischemic encephalopathy and is considered rare in the term neonates. Then the manifestations by CT and by MRI, of course, MRI is more sensitive. There is ventriculomegaly with abnormal configuration and undulation of the ventricular surface. And you see that the ventricular wall is somewhat lobulated and the ventricles are non-uniformly dilated. Also, you've got loss of the periventricular white matter, especially in the common areas around the trigone of the lateral ventricles. If you compare the white matter in the frontal lobes, it is somewhat good, but there is marked reduction of the white matter in the occipitoparietal area. Also here in the T1, you see the white matter in the frontal lobe is good, and there is marked reduction of the white matter compared to the posterior aspects of the ventricles. There may be thinning of the corpus callosum, and late in the disease, the ischemic white matter will develop cystic changes of encephalomalacia. This is also a case of periventricular leukomalacia in the T1, T2, and the FLAIR weighted images. The changes are evident in all bulk sequences, and you see the abnormal signal in the white matter and the reduction of the size of the white matter itself, and also the appearance of the ventricular wall. And this is also another case, T1, T2, and the flare. Then you can see the abnormal signal of the white matter, which will be bright in T1 and in T2 and the flare weighted images. And also you look to the ventricular wall, which is lobulated or undulated. Late in the disease, there will be cystic changes of encephalomalacia in the white matter, which means that this is the end stage of the disease. Then we came to the germinal matrix hemorrhage, and this also is commonly seen in the premature infants. And the germinal matrix is the layer which is located in the ventricular wall, responsible for the formation of the cortex, as I have mentioned in the lecture of cortical formation. And this germinal matrix will involute except the region in the near the head of the caudate nucleus, which is the most common site to develop this type of hemorrhage in the premature neonate. Then this hemorrhage occurring intimately related to the ventricle, it may have an access to enter the ventricular lumen, and this may result in obstructive hydrocephalus and ventricular dilatation. Then hemorrhage may extend also into the brain parenchyma, and according to the size of the hemorrhage and the extent within the ventricles and then the size of the ventricles, we have the grades of germinal matrix hemorrhage. One important note is that the preterm infants should be routinely screened for this germinal matrix hemorrhage, and the best way is, of course, by the transcranial ultrasound. These are the grades of germinal matrix hemorrhage. Then grade 1, when hemorrhage is confined to the region of the caudate nucleus or the germinal matrix. In grade 2, when hemorrhage is extended inside the ventricle, but the ventricle is not dilated. Grade 3, when hemorrhage is inside the ventricle and the ventricle is dilated. Grade 4, when hemorrhage occurs also within the brain tissue. Then one of the important tools for screening of premature infants is the transcranial ultrasound, and you can easily appreciate the hemorrhage within the ventricles which are dilated, indicative of grade 3 germinal matrix hemorrhage. The clinical presentation is usually in the form of cerebral palsy, mental retardation, and seizures. Then this is an ultrasound. This is coronal and sagittal ultrasound or transcranial ultrasound showing the echogenic hemorrhage in the region of the caudate nucleus, and also can be appreciated in the sagittal image. This is a CT scan without contrast showing there is germinal matrix hemorrhage in the region of the head of the caudate nucleus bilaterally, with extension of the hemorrhage within the ventricles, which are more or less not dilated, indicating that this is stage 1, stage 2 germinal matrix hemorrhage. But in this stage 3 hemorrhage, you can see hemorrhage in the germinal matrix and intraventricular blood, and the ventricles are dilated. And this is grade 3 germinal matrix hemorrhage by sagittal ultrasound, and you see the echogenic blood within the ventricle, and ventricle is dilated, and also you see the hyperdense blood within the ventricles, and the ventricles are mildly dilated. And this is also an example of germinal matrix hemorrhage grade or type 3 by ultrasound and by MRI T1 and T2 weighted images. In the ultrasound, the ventricles are dilated and they contain echogenic blood. In MRI, the ventricles are considerably dilated and they contain blood of high signal in the T1 and relatively decreased signal in the T2, denoting the presence of subacute blood products. Germinal matrix hemorrhage will lead to destruction of the germinal matrix, will lead to periventricular hemorrhagic infarctions, and when hemorrhage regress, it will leave areas of encephalomalacia, and due to the obstruction of the CSF pathways, there may be hydrocephalus. Then we have exposed these abnormalities in the preterm infant, including the periventricular leukomalacia, the germinal matrix hemorrhage, and its extension inside the ventricle as well as in the brain parenchyma. Then we came to the changes in the term infant, which will include the global ischemia, the cortical and the subcortical infarctions, the parasagittal watershed infarctions, and the focal ischemic changes. And the global cerebral ischemia is one of the manifestations of hypoxic ischemic encephalopathy, where there is diffuse involvement of the brain parenchyma, including the white matter and the gray matter, and this appearance is almost common in cases of hypoxic ischemic encephalopathy in the term infants, where you got extensive hypodensity of the cerebral tissue. There may be sparing of the basal ganglia, and commonly there is a sparing of the cerebellum, and this sign is referred to as the white cerebellar sign or the reversal sign. And here you see that there is a diffuse hypodensity of the white and the gray matter of the brain parenchyma. And you remember that in early post early neonatal period of the term infant, you know that the white matter has a lot of water content, and it will appear hypodense on the CT and low signal in MRI T1 and high signal on MRI T2 weighted images. But you remember that the cortex is not affected by this water content. The cortex will appear of a relatively isodense signal, or it will show normal signal on MR images. But there are two main findings in the CT and the MRI to predict that this is not the normal appearance of the brain tissue. The first one is the affection of the cortex by the hypodensities in the CT, the low signal intensities in MRI. Number two is affection of the basal ganglia, and the basal ganglia is spared in most of the cases, but affection of the basal ganglia is an indication that the changes you are seeing in the brain parenchyma are not due to the normal water content in this early neonatal period. Then here, if you look here and you see this is the white matter only, which is affected by hypodensities. The basal ganglia is intact and the cortex is also intact. At that time, it's very difficult to diagnose hypoxic ischemic encephalopathy by CT and by MRI because this may appear to be the normal water content of the white matter at this age group. And if you have the MRI, the water content of the white matter will appear low signal in the T1 and high signal in the T2. Then you need at that time the help of diffusion weighted images by MRI to separate the normal water content from the ischemic white matter. And as I have mentioned, there are some clues to predict whether these changes, this is an infant 3 days old, and this is considered normal white matter hypodensity in this very early neonatal period. But one of the clues that this is ischemic changes is the appearance of hypodensities in the thalami and the basal ganglia, and this is one of the signs. Then global cerebral ischemia will appear like this on the CT images. There are diffuse hypodensity affecting the cortex and the white matter, and there may be some sparing of the basal ganglia, and sometimes you see that the cerebellum is also spared. Then ultrasound is good in this particular domain. Number one, it can exclude the presence of hemorrhage. It can exclude the possibility of periventricular leukomalacia, and it also can assess if the patient had hydrocephalus or not. But CT is considered the least sensitive modality for evaluation of hypoxic ischemic encephalopathy in the early neonatal period because of the increased water content of the neonatal white matter in this very early stage. Then, as I have mentioned, you need the help of diffusion weighted MRI images, and this is considered the most sensitive to evaluate the diseased areas. And here you can see these bright signals in the basal ganglia as well as in the cortex and the subcortical white matter. The areas which will show diffusion restriction, they will appear bright whenever the CSF is black, indicating that these are abnormal ischemic areas. And here is the CT scan showing diffuse hypodensity of both cerebral hemispheres with a sparing of the cerebellum and relative sparing of the basal ganglia. An MRI, and this is T2 weighted image, and you can see some brightness in the cortex, but the white matter is more or less appearing good. If you see the post contrast image and you see the white matter is relatively myelinated and uh, uh, there is some abnormal enhancement in the cortex of the brain corresponding to the areas of high signal and the T2 weighted image. But if you look to the diffusion weighted images, and you can see that there is considerable diffusion restriction in the white matter denoting its involvement. Then in severe cases of global cerebral ischemia, you see diffuse hypodensity of the white and the gray matter involving the cortex and the white matter. There may be sparing of the basal ganglia and also sparing of the cerebellum. And this sparing of the cerebellum is known as the reversal sign on CT and is usually associated with bad prognosis. And MRI can also assess the possibility of hemorrhage depending on the signal, can see cerebral infarctions, can also exclude the possibility of neoplasms and also assess for the presence of congenital malformations. This is a good example of hypoxic ischemic encephalopathy with the reversal sign or the white cerebellum sign. The brain tissue is relatively black compared to the cerebellum. There is loss of the gray-white matter interface. There is affection of the cortex as well as the white matter. And this is the white cerebellum or the reversal sign, where you can see that the cerebellum is of normal CT density, while the rest of the brain parenchyma is hypodense. Sometimes you got a sparing of the basal ganglia with the cerebellum, and other times you can see that the basal ganglia are also involved. And the involvement of the basal ganglia is usually carries a bad prognosis for the patient. And this is an example where you can see that the caudate and the lentiform nuclei are appear markedly hypodense or ischemic together with some changes in the brain parenchyma. And this is usually seen in what's known as near drowning, where um, there is transient cardiac arrest and asphyxia, which may occur after submission in water. And most of these infants or children will have severe neurological impairment, and only 1/3 of them may remain neurologically intact. In MRI, you got some of the manifestations previously seen, like focal or generalized brain edema at first, which will lead to ischemic insult after that, basal ganglia affection, cortical abnormalities, and the brainstem infarctions. In the first 24 hours, the presence of edema in the basal ganglia, which include the lentiform and uh, the caudate nuclei as well as the thalami, is sensitive and specific for poor outcome, as I have mentioned. And this is a post-mortem non-contrast CT brain scan showing extensive involvement of the cerebral tissue with severe impact on the basal ganglia, the caudate and the lentiform, as well as the thalami, together with the most of the brain tissue, sparing the cerebellum. Then also the changes in the basal ganglia may not apparent on CT and the usual MRI, and you may need in many times the help of diffusion weighted images to see restricted diffusion in ischemic areas, as you can see in these basal ganglia. This is the body and tail of the caudate nucleus, this is the lentiform, and this is the head of the caudate. And hypoxic ischemic encephalopathy later on will result in cystic encephalomalacia in the brain parenchyma with severe damage of the brain tissue and the consequent dilatation of the ventricles due to loss of volume of the cerebral tissue. And involvement of the cortex may lead to what's known as cortical laminar necrosis. And this cortical laminar necrosis usually appears in the CT scan as hyper dense serpiginous like areas within the cerebral cortex. And it was thought that these hyperdensities are due to hemorrhage, but according to the literature, they are due to denaturated proteins in dying cells, not due to methemoglobin or the blood products. The cortical gray matter involvement will result in this disease, which is the cortical laminar necrosis, and this will appear in the CT scan as hyperdense serpiginous cortical lesions, and also in MRI, it will show hyper intensity on the T1 weighted image. And this is a case of hypoxic ischemic encephalopathy, and it shows clearly the white cerebellar sign sparing of the basal ganglia. Then 10 days later, the CT scan showed extensive changes. The cortex showed these very well demonstrated hyperdensities representing cortical laminar necrosis, and also the start of dilatation of the ventricular system, denoting the loss of volume of ischemic brain tissue. And this patient was brought unconscious to the casualty with low pulse and blood pressure. And you see here the changes in the basal ganglia as well as in the cortex of the brain tissue. In basal ganglia involvement is usually bilateral and symmetric. It is one of the manifestations of hypoxic ischemic encephalopathy. The affected basal ganglia will include the thalami, the caudate nuclei, and the lentiform nuclei. Sometimes involvement of the basal ganglia is seen isolated from involvement of the brain parenchyma or may be associated with involvement of the brain parenchyma. And you see here there is selective involvement of the basal ganglia, which show high signal intensity in the lentiform and in the thalami. And this is also an example of a near drowning insult with more or less selective involvement of the basal ganglia. You see the head of the caudate nucleus is hypodense, the lentiform nucleus, and the thalamus. Also, you can see some small frontal subdural, chronic subdural hematoma. And this is a patient who attempted suicide by hanging. Then you see the global cerebral ischemia. There is diffuse hypodensity of the brain parenchyma involving the cortex and the medulla, selective involvement or severe involvement of the medial part of the lentiform nuclei, the globus pallidus, and you can see that the cerebellum is spared, what we call the reversal sign or the dense cerebellar sign. And this appearance is sometimes commonly seen in the clinical practice, which is an indication of profound hypoxic ischemic injury to the brain parenchyma. And this is usually seen immediately before death or even after death. This changes, as you can see here, there are extensive hypodensity of the brain tissue. There is some sparing of the basal ganglia, and you got areas of hemorrhages, especially in the subdural space. And you see here hemorrhage in the sylvian fissure and hemorrhage related to the posterior part of the enterohemispheric fissure, denoting its subdural location. And this hemorrhage is actually not secondary to trauma as was suspected to be in difficult deliveries or so, but this hemorrhage is due to ischemia of the vessel wall, and this ischemia will result in damage of the vessel wall, resulting in hemorrhage. And here you can see that the brainstem and the cerebellum appear relatively hyperdense. They are spared from this ischemic insult. They see diffuse hypodensity of the brain parenchyma, and they see the areas of hemorrhage within the sylvian fissure. There is obliteration of the quadrigeminal cistern. The quadrigeminal cistern is here due to swelling of the brain parenchyma, which is usually an indication of impending conization. Acute tentorial and the posterior falx subdural hematomas are usually the sequelae of ischemic vasculopathy, which will result in the damage of the wall of the vessel and the bleeding in the subdural space. Also, there may be subarachnoid hemorrhage. Then this is the post-mortem brain damage. As I have mentioned, this is an indication of profound cerebral ischemia whenever you see the global hypodensity of the brain together with hemorrhagic spots in the subarachnoid and in the subdural space. Then one of the changes of hypoxic ischemic encephalopathy is what's known as the watershed infarctions or the border zone infarctions. These infarctions occur between the territories of the vessels. In here you see this is the vascular territory of the anterior cerebral artery, and this is the yellow is the vascular territory of the middle cerebral artery, and the green one is the vascular territory of the posterior cerebral artery. Then the watershed infarctions occur at the zones between the territories, like in this area between the anterior and middle cerebral, and this area also between the middle cerebral artery and the deep cerebral the, the vessels related to the ventricular wall, and here between the middle cerebral and the posterior cerebral artery. And this is a watershed infarction. If you go to the drawing, it occurs here between the middle and the posterior cerebral. And here, this is a wedge-shaped area of abnormal signal intensity between the middle cerebral and the posterior cerebral territory. And of course, the watershed infarctions are the sequelae of drop of the blood pressure that is unable to maintain the capillary pressure essential for tissue perfusion. Then you got an ischemic area between the vascular territories like this one between the anterior cerebral and the middle cerebral. And these are also watershed infarctions between the cerebral vascular territories. They show high signal in the FLAIR image. And you know, these infarctions, they may be bilateral and sometimes they are symmetric. And here is a diffusion weighted image showing diffusion restriction in the medial aspect of the left cerebral hemisphere, representing a watershed infarction. The end stage of hypoxic ischemic encephalopathy is the appearance of a totally damaged, destroyed brain parenchyma, which is the seat of multiple cystic areas of encephalomalacia with dilated ventricles to compensate the loss of volume of the ischemic tissue, and there may be foci or areas of calcification within the dead brain tissue. Infarction is an area of focal cerebral ischemia, and this can also occur in the pediatric age group. It's not that common like in adults, but sometimes you can see a focal infarcted area in the children. And I used to mention that infarction is not a space occupying lesion, meaning that the mass effect exerted by infarction is usually due to the associated brain edema, and this is an indication that this infarction is in the acute stage whenever it is compressing the ventricle. And this is a patient with endocarditis showing an infarction in the temporooccipital area. It is cortical and subcortical in distribution, similar exactly to the infarction seen in adults. And you can see there is some compression of the adjacent ventricle. And this is also an acute infarction in the basal ganglia, affecting the head of the caudate as well as the lentiform nucleus, with a mass effect on the right lateral ventricle. This is also acute stroke in the frontal and temporal areas. And here you may be able to see that this lesion involves the common carotid territory, including the anterior cerebral and the middle cerebral, with consequent some mass effect on the left lateral ventricle. And this is also the bilateral occipital infarctions affecting the posterior aspect of the brain with some mass effect on the adjacent ventricles. This is left cerebral infarction affecting the left cerebral hemisphere, which appear relatively hypodense compared to the normal right cerebral hemisphere. The changes are not well appreciated in the T1 weighted image, but they are relatively appreciated in this T2 weighted image, which is performed 3 days after the CT scan. And the result of an infarcted brain tissue is the loss of volume and atrophic changes. Whenever the infarction affects the whole cerebral hemisphere, there may be the changes similar to this, which is known as cerebral hemiatrophy. And then this cerebral hemiatrophy, you will see number one, eccentric position of the falx cerebri, dilatation of the ventricle in the atrophic hemisphere, as well as dilatation of the cortical sulci, sylvian fissure, and all the extraaxial CSF spaces. There may be some parenchymal areas of encephalomalacia as well, compared to the normal sized hemisphere. Then a few words about the non-accidental trauma, or what we call the battered baby syndrome or the shaken baby syndrome. Of course, if we shake our babies, there may be some insults in the brain parenchyma because of the relatively small size of the brain compared to the size of the skull. Then any shaken maneuver will result in variable damage to the brain in some time. Then it is recommended not to shake in your infant by any means, because at that time he is liable to develop brain injury because of this shaking procedures. And I will show some of the examples which are included under this title, the shaken baby syndrome. And here you can see a focal area of hemorrhage, and also you can see widening of the frontal subdural space, and this will result from a tear in the arachnoid membrane, and this will result in leak of the CSF from the subarachnoid space into the subdural space, resulting in this appearance, which is known as the subdural hygroma. And this is also an example by MRI T2 weighted images. And here you got damage of the brain vascular blood supply with extensive hypodensities in the occipital lobes seen by CT and also by MRI T2 weighted image. They are of bright signal, and this will progress into brain damage and atrophic changes and permanent insult, of course. And this is also a subdural bleeding secondary to this syndrome, which is the shaken baby syndrome, where the CT scan in the axial images showed the presence of blood in the subdural space. And this blood is of two components, a hyperdense component and a hypodense component. And this is known as a swirl sign, and it means that there is a hyperacute bleeding, which is a very, very recent bleeding of mixed densities. Low densities represent the unclotted blood, and the hyperdensities represent the clotted blood. The mixture of hypo and hyperdensities, and you see the extension into the tentorial leaflet as well, and the extension into the posterior part of the falx, and this means that you are dealing with hyper acute subdural hematoma. Thank you very much. Alhamdulillah Rabbil Alamin.